When I went to prepare for the presentation, the discussion we had amongst the panelists gave me that deja vu all over again kind of feeling, and so I went looking for on Google Images something that would express that, and whether it's Web 2.0 or realignment, I think the notion's the same. It feels like everything has changed, and seriously, then how come they still make fajitas out of us? The risk is that plus que change, plus la même chose. And what leads me to feel that way is that, and Gail talked about the work of the Planning Council around measurement and outcome evaluation going back to the 1980s. In 2001, I chaired a committee that sprung out of ACMA, and we brought together the accrediting organizations nationally with the hopes that they had the, if nothing else, the moral authority to force some agreement in the field around a common universal set of measures. And here we are yet again. And one of the reasons that we didn't succeed is because we could agree in principle about what we ought to measure or attend to. But what was really fascinating is that when we got down to the specifics of which actual tools, instruments, and measures we should or could choose, there was total disagreement and chaos. And that seems to have been perpetuated. Now, I'm a bit of a stand-in here this morning, and had it not been for scheduling problems, Cricket Mitchell would have made this presentation. I really want to acknowledge her work, Lynn Marsenich's work, and Todd Sosna's work in developing palliative measures. This slide is to remind you that when I say pallet, I don't mean one of those wooden things that stacked with boxes in a warehouse, as if all of our potential measurement strategies were loaded up there, but rather the idea of an artistic palette where there's a range of colors and hues to choose from, and that they're complementary and all mix well together. Those of you who know me know that I'm a champion for person-centeredness. I was delighted that Ron reminded us that this must be a central theme in all the work that we do, and I think it should be the overarching premise or principle as we approach measurement. Now clearly, we've heard a lot about the importance and the value of a population or public health-based approach to measurement, and that is also equally important. But I think when it comes to looking at the treatment component of the services that we provide and the responsibilities that we have, that we really need to be person-centered in all respects, and I think that means for me starting at the person, at the client level, and the interaction between the client and a provider in terms of how we gather data and how we use data. So the palette of measures is intended to support agencies to develop the capacity to routinely, on a regular, daily, day-in, day-out basis, to use clinically relevant tools and evaluate the performance of services across all clients. And I know that as a clinician, what I've often hungered for has been real-time, easy-to-gather information that's reliable, that comes from the client, that tells me about whether or not progress is being made, whether or not symptoms are being reduced, function improved, whether or not goals and objectives in a treatment plan are being met, and to adjust the treatment accordingly. Ron talked yesterday about shared decision making, and I think that information, the ability to evaluate risk and benefit, is at the heart of any decisional process, and yet we all come at it with relatively limited information and data. And there's some basic, simple questions. Are services working, and for whom? Are individual clients making progress? And what services are working and not working, and why, and what adjustments do we then need to make? We've had some success at CIMH in beginning to get some buy-in into this palliative measures framework. Cricket did present at the last policy forum briefly and showed some early bit of work that we've done in development, and it has generated interest. My hope here today is that it will generate yet more interest and create a platform with which we can find ways to collaborate, and I think the work that LA County is doing is really very reflective of this approach. The idea is that we want to support accountability, and we have accountability at many different levels. We've got accountability to millionaires who pay the MHSA tax, but I think primarily we have an accountability to the clients and the family members that we serve. And what we want is to be able to start with patient-centered data and then move to be able to aggregate it so that we can look across programs, we can look across clinics or agencies, we can look at the performance of individual providers or teams, in a quality improvement framework, I think there's some tension between the notions of accountability and quality improvement, and they ought to be at least acknowledged, because we want to approach this with an emphasis on quality improvement and not just simply quality assurance. That would be a step backwards for us. What the palliative measures approach does is really, I think, rather brilliant, because it sidesteps this whole issue about let's stop fighting about my measure is better than your measure, and say, look, there are some general principles about measurement we can agree upon, there are some general domains, and what I want to try and illustrate is that there's a lot of room for latitude in terms of what we individually or specifically measure, and at the same time have a great deal of commonality, which is part of what we also need in terms of this larger public obligation of accountability. So some of the criteria that you want to use to include any particular measure in the palette is that there's parsimony, we reduce burden, we make it fit into the workflow and into the clinical process, so that when a client and family member come in to seek services, they have the ability to inform the provider and record information that becomes useful in real time. We've settled on what I will call now 3 core domains or central categories of information. We want to know the characteristics of the client served, who is the individual, what are the services that they get, and I think being able to support quality improvement, so we always are evaluating efficacy and effectiveness, is critical. And then, can we measure change? Is there progress? And I think one of the important things there is that we be able to do this in as close to real time as possible. In a recovery environment, we should, in our measurement strategies, communicate the expectation of hope, and that we expect there to be change and improvement as a result of services, and to blow the whistle and say stop for a minute when we see services not proceeding and producing positive change for clients. I'm going to skip through, like Debbie, some of the slides. I included too many, and I do want to be brief here this morning. We do think that there should be 2 outcomes at a minimum that are collected for each intervention being evaluated. In some instances, they can and should be highly specific to the treatment that's being targeted, and certainly the symptoms that have prompted the selection of that particular treatment or intervention. And then we also need more general measures of mental health and community-based functioning. One of the things that we're really excited about at CIMH is building off of the work and the investment that we've made and that all of us have made in the state in the Consumer Perception Survey, because the data collection method has tremendous promise, and it builds on what historically was called teleforms. The technology's been around for a long time, but it has advanced substantially, and it makes it very easy to capture data in multiple formats, whether it's touchscreen tablets, on computers with a mouse, or paper and pencil, and filling out the little bubbles. But it's flexible and responsive and low cost, and we've made a big investment in the systems that are necessary to manage this data for the Consumer Perception Survey, and we think there's an opportunity for the entire mental health practice community to build on that and access that system for the kind of data availability and turnaround that collection availability and turnaround that I'm trying to describe. One of the things that has been part of the mantra of the work we've done around care integration has been the notion of treating to target. We need to know what the target is, and we need to know what our progress towards that is, and that's the kind of data collection and use I'm talking about. Steve Leff at HSRI is one of my heroes and has been one of my mentors in my career, and he always talked about the ability to take a mix of measures and calibrate them. And the idea is that if we are looking at the domain of functional improvement, someone may want to use the COQ, and someone else may want to use the SF12, and someone else may want to use the ABC. In a sense, it doesn't really matter, because conceptually what we have is the ability to find out how to translate from one measurement to another. So if we all agree upon the domains, we can have multiple degrees of freedom in terms of what we actually use day in and day out in our setting, because we like it, because we've used it, because we think it's best. and sidestep the argument about everyone must use one measure, one tool, and find a way at the same time to preserve some comparability in data that's useful for us because it supports our quality improvement efforts. So we're mingling, we need to talk about calibrating, and then lastly, aggregating. We need to aggregate, we need to come together and reach some kind of consensus on all of this, and at the same time, we also need to be able to collect data that we can aggregate, that we can roll up, that we do need to start on the one hand at the client level. On the other hand, we need to be able to look at the performance of our own teams, our own clinics, our own counties, and the state overall, so that we meet our accountability obligations, as well as have an environment in which we can use data for ongoing continuous quality improvement. Thanks very much, and I'm now going to turn it over to Karen.